Good afternoon, everybody. Today's topic, we're going to talk about chest tube systems. We'll talk about several different atriums. Then we're going to talk about how to manage the chest tube itself. All you have to do is sit back. I'm going to go through the slides. I'll talk a little bit about each one, and we'll work our way right through all the systems. Okay, here we go. Okay, so you'll get your chest tube tray in the room. You'll start to open it up. You're going to use sterile technique doing that. The other thing I'd suggest is that you have wall suction up and ready. Get your canister up there or whatever setup you have. Get it ready to go. Open this up using a sterile technique. Now the ones we talk about today, they all use the auto transfusion and they have that ability, but I won't go in depth on that right now. Just want to talk about the different atriums that you can run across, but you want to use good hand hygiene. So put on your sterile gloves when you're opening up the blue wrappers on the kit and you're getting into the tray itself. After you remove the atrium from the molded plastic tray, on the bottom there's a swing out stand. Go ahead and turn it like you see in the picture. That way you're able to set it upright while you fill the chambers and we get everything hooked. Now on the back of the atrium you're going to find this ampule, and it has 45 cc's of pre-filled sterile water. So you're going to remove that from the back. You're going to twist the very tip of it off, and I'm going to show you how to squeeze the entire ampule into the suction port on the top of the atrium. Now you're going to stick it into that blue suction port on the top like you see in the picture. You're going to squeeze the entire ampule into that chamber. Squeezing in that 45 cc's of sterile water into the water seal is going to raise it to the correct line, which is 2 centimeters in the chamber, and I'll show you a picture of that. Here's a picture showing you after you put the 45 cc's in. You'll see where the water line comes up to that 2 centimeter mark. Now you can remove the tubing from the back of the chamber. You can remove the sterile cap that you see above in the picture before handing it to the doctor to go ahead and complete the connection to the patient. Now when the doctor's ready, go ahead and hook up the wall suction tubing to the suction port on the top of the atrium like you see here in the picture. You'll see right above the word atrium, there's that little black triangle. It's the only place really you can hook it up. Just slips on right over the top. And I put a picture up here because your next step is to set the wall suction itself. I would tell you go ahead and set it at -80. That should be sufficient enough. Most textbooks say you can go higher, but I would say you're pretty safe just setting it at -80. Now let's take a look where his finger's pointing, where it says E on here. Now that's a bellows in there, that little orange accordion looking thing. And when you have this set up right and your suction is on, the bellows will come out and it should go just past that little white triangle you see through that window. That'll tell you have everything set correctly at this point. It's also an indicator to you that your suction setup and the suction itself is working correctly. Okay, the next thing to be aware of is take a look here below where it says A. There's like that clock looking thing with the orange hand in it. It's set at -20. It's going to come preset like that when you take it out of the package. That's where most physicians are going to want it set all the time. You can adjust it, and I'm going to show you how in a minute. There's a rotary dial on the side of the atrium. You can set this anywhere from -10 to -40, but you don't want to do that without a physician's order. So for the most part, you're probably always going to have it right at -20. Now this picture is just showing you right next to it where that -30 is on the side of the atrium. That's where that rotary dial is, and you can dial it up or down to readjust that negative pressure if you needed to. Again, I hate to beat it into the ground, but make sure you have a physician's order if you're going to change this setting. Set it on the floor. Make sure the swing out stand at the bottom is out. You can do it that way. The other way are there are hooks, and I'll show you a picture here in a minute. You can hook it to the bed frame rail if you want to, or like I said, just set it on the floor with the knockout stand that's on the bottom. Okay, and here's that picture showing you how it's hooked to the bed frame rail. It's another acceptable way of doing it if you didn't want to leave it on the stand on the ground. Next, you want to make sure that you set this whole atrium down on the ground, and it has to be below the patient's chest. Okay, now after that, another quick easy thing to do is make sure you don't have any dependent loops in that drain tubing. One way to do it is you can just drape it up on the bed like you see here in the picture. So there's, like I said, there's no dependent loops. Now if the patient's out of bed to a chair, you want to make sure and do the same thing. The reason behind this is it allows for gravity drainage to occur, and it prevents pressure from building up inside of the tube, and then it backs up into the actual pleural space of the patient. So those two problems are alleviated just by making sure you don't have any dependent loops. Okay, so the next thing you want to do is you want to take a look at the quantity of fluid coming out, and you want to take a look at the quality of it. What does it look like? And then you want to put a date and a time per shift is what we usually do, and then you'll know how much is coming out per shift or how much is coming out in 24 hours at a glance, and for your charting, of course. One of the questions that's often asked is how much is too much fluid? And a basic guideline I think to go by where you would be safe is to say, look, if it's putting out 100 cc's or more in an hour, you might want to let the surgeon or the doctor know. It's just a good safety precaution in case there's something going on that they need to be aware of. So now you look down and you see bubbling in the chamber like you do in the picture I have here. And if you look where the 0 is, you'll see where there's a bubble in there, where I kind of froze the frame, but you'll see bubbling occurring. And you know that you have a leak then if you've got that bubbling. And you also notice there's a graduation down here where it goes 1 down to 5 that can tell you the severity of the bubbling. But we know that there's a problem, and we know there's an air leak because of the bubbling. So the next thing to do is we have to troubleshoot, well, where's it coming from? Well, it can be coming from the insertion site where the tube goes into the patient. There could be a leak right there under the dressing or near the dressing, or it could be in the tube itself. And as you come down, the only other possibility would be that the atrium itself is cracked or damaged and it's leaking. So you know that it's in one of those places, and now it becomes, okay, how do I troubleshoot it to figure out where my leak's occurring? Now, the bubbling can be continuous or it can be intermittent, either one, but both are demonstrating that there's a leak. So let's start up near the patient. Let's go up real close to where it goes into the chest and pinch the tubing off real hard, or use Kelly clamps and clamp it. And then let's take a look down and see whether or not we still have a leak. If the bubbling stops, it tells you that the leak is in the insertion site or right there, and then that's where your problem is, or it could be inside of the lung itself. If the bubbling continues, go down to the first connection point coming away from the patient, pinch it again real hard and see if the bubbling stops. Let's just say it stopped. Well, then you know your leak is in that connection, and you might have to undo that tape, re-secure your connections, retape them, or whatever the physician's ordered. But let's just say it kept leaking. You saw the bubbling still in the chamber. Then start going about every 12 inches and pinching it off and clamping it tight with your hand. See whether or not the bubbling stops. If it doesn't, continue doing this all the way down to the atrium. Now, if you get all the way down to where you see here in the picture where the atrium is and you pinch it off and it's still bubbling, then it's in the atrium itself, and you're going to need to change out that atrium. Here's a quick side note. Anytime you're clamping this off for any reason while it's hooked to suction, and you have everything hooked up and it's functioning right, you never want to leave it clamped off more than a few seconds. You can do a lot of damage, if you leave it clamped off for too long. Somebody said, what's the reason why? Well, you can cause a tension pneumothorax really easy if you left it clamped off for an extended period of time. Kind of like what you see here in the picture, and you can see the damage because it can create brachial deviation and it can cause a lot of problems. So never leave it clamped for longer than a few seconds. Like I said, even if you're changing the atrium out, you should have the atrium all set up ready to go and be able to switch them very rapidly and then release the clamp. Okay, let's take a moment. Let's discuss that you discovered there's a problem with the atrium itself after you troubleshooted the leaks and you know that you need to change it out. It has a clamp that comes with it. You'll see here in the picture where the guy has his two hands on that blue slide clamp. So you're going to have to do this quickly. Like I said, you don't want to leave this clamped off for any length of time. So you're going to slide that so that it kinks off the tubing. You're going to disconnect it then, and you should have the other one already set up and ready to go. Then you're going to connect the new one on there rapidly, And you're going to go ahead and you're going to release that clamp like you see here in the picture, where he's releasing it back into the big circle on the clamp. Then go back, like I said, through the little check off. Make sure you have the negative pressure set correctly. Make sure you have your wall suction set correctly. And take a look at the things that we discussed and make sure it's fully operational again and working like it should. So the question comes up when I'm connecting these and I swap the atrium out, where the two of them connect right there between his two hands. How do I know that I've connected it correctly? You're going to hear a click when you push those two connections together. When you hear that click, you'll know that you have a good secure connection. Now take a look at the picture. You're going to see here in about the center where it's got +2, +1, 0, and then it goes on up. And I blew it up pretty good, but you'll see the little round white ball there. Now that ball is going to move up and down with inspiration and expiration. Now when it does that, the term that they use, it's called titling. And it shows up and down movement. So when a patient breathes in, it creates this negative pressure. That's the inhalation part, and the float moves up. And then when they exhale, it creates a positive pressure, and it pushes that little white ball down. So as they breathe, that float goes up and down. Now the exception to this is if they were in ICU and they were on a ventilator, it would have the reverse effect because they're on a ventilator, and the ventilator is creating positive pressure. So it's going to be the opposite of what's normal of what we're talking about, but I'm just putting it in here for completion's sake. Somebody had mentioned, well, what happens if they're on a ventilator, or what happens if they're getting PEEP, which is positive end expiratory pressure. Well, those things have the reverse effect. So, but for the sake of this and bedside care, we'll assume they're not on a ventilator. You'll see here in the picture where it's way up near the 20 mark with the patient breathing in and out, and somebody says, well, is titling really important or something that I really have to know anything about? Well, it is. You're not going to see titling if you have an air leak. So that's one way of being able to know that there's kind of a problem there. Now, are there any other reasons that you won't see titling? Well, anytime the tubing is occluded, you won't. And when the lung is fully expanded again, you won't see titling either. So it's one, it could be that. It could be the lung now is fully expanded, and that's good. So, you won't see that titling effect. Where titling will be a lot more noticeable to you is when there's no more suction applied and the suction's been turned off. Then it's a lot more noticeable. Okay, now it's a good time to go back and let's check the settings. You can see where that little bellows is below the E. If it's disconnected from the patient, is it deflated back the way it should be? Or if you have it to suction, is it out just past that little white triangle like it should be? You can look at your negative pressure setting above the E and below the A. Is it still set to -20? So you're verifying your settings at this point. And is the wall suction on like it should be? Do you have it set to 80? Okay, so now you have an order where it's to be to water seal. So you have to make sure that you've disconnected the tubing from the top like you see here in the picture. Okay, and if the order is it's to be to water seal and you've disconnected the suction tubing, like I was saying, you should notice that the bellows is not expanded. You can see where his finger's pointing down where it's marked E. Now the next thing is let's say the physician wants a sample of the fluid sent to the lab. How are you going to do that? Well, these have sampling ports on them, and I've got a picture of it right here where the finger's pointing right at that port. And it has a luer lock tip on it, so any sterile syringe, and yes, you should always use sterile syringes, will screw right on there. Now before you attach that syringe and get your sample, you want to clean the site real well with an alcohol pad. Now the standard is to scrub it and rub on it for 15 seconds. Then you're okay to go ahead and hook up the syringe and get your sample. Now you can go ahead, hook the syringe on there, gently pull back on it, tilt the tubing, and you can collect your sample. So one of the questions comes up, what happens if a patient dislodges the tube and it comes out because he rolled in bed or something happened? One of the things that you can do while you're waiting to get a hold of the physician or for the physician to come, you can put an occlusive dressing over the site, but you don't tape all 4 sides. So with the occlusive tape, you're going to do it to all 3 sides. You're going to leave one side open like it shows you here in the picture. And so the question is, well, gee, what happens if I did put all 4 sides on? Well, what you do is you increase the pressure and the tension on the lung internally. So by leaving that one side open, that won't happen, and the patient should be safe until the physician or the surgeon arrives. Okay, this is going to conclude the chest tube drainage system review and a little bit on managing the lines and troubleshooting. The next one will be on the Teleflex system. It's a chest tube drainage system. We'll go over that. It has a lot of the same similarities as everything we've been through. You're just going to apply a lot of the same techniques that we talked about here to the new Teleflex chest tube drainage system. Okay, that's part 2. It'll be coming up. Thank you, folks, and have a great day. Bye-bye. Okay, so we are going to have a discussion on the Teleflex Pleurovac chest tube drainage system. Okay, so step 1 is you're going to remove the little funnel from the very back of the unit. You're going to turn around and you're going to place it, like it shows you in the picture, on the hose that goes to the water seal chamber. And you're going to fill it up to the line, which is the 2 centimeter marking. Now with this unit, it's going to require 70 cc's of sterile water or saline. So just like in the other ones, that funnel is going to connect to the suction tubing that's coming on the top of the atrium. And you're simply going to fill it, just like it shows you here in the picture in figure 1. Okay, now the next thing you need to do is you need to fill the suction control chamber with either sterile water or saline. So what you're going to do is you're going to remove the atmospheric vent cover. It's a little muffler. It's right next in front of that suction tube. It's like a plug. You're going to remove that. And you're going to go ahead and fill this atmospheric chamber, or vent that they call it. You're going to fill it up to the 20 centimeter level mark, or as prescribed by the physician, but it's generally going to be up to the 20 centimeter level mark. Replace that atmospheric vent cover securely after you fill it up, and you're good to go. Okay, so now what you're going to do is you're going to connect the patient tube to the thoracic catheter, like it shows you here in picture 2. Just connect it to the one coming out of the patient, and you're done. And that's all there is to it if there's no suction required. Okay, going back to step 1, you're going to fill that water seal chamber to the fill line. And that's the one that shows you that this is 2 centimeters of water at the level. And it's going to take the 70 cc's, just like what we discussed earlier in step 1. The funnel is provided, it's on the back of the unit. Then you're going to go ahead and you're going to connect it to a suction source. Like I'm showing you here in the picture, there's one end that connects to the patient and the other is the suction tubing. That's the one that's going to go to your suction source. Then connect the patient tube side over to the thoracic catheter, which is the chest tube coming out of the patient's chest. Okay, looking at figure 2, we know that we have to apply suction to the atrium. So, because suction is required, we're going to connect the suction tube to the suction source. Once it's connected, up on the wall, you're going to increase the suction until you see gentle bubbling occurring in that suction control chamber that you see in figure 2. The height of the water in that chamber is what determines the amount of suction, so just fill it up like you're supposed to the 20 centimeter mark. Okay, a word of caution here, you always want to make sure that you keep this Pleurovac below the patient's chest level at all times, and remember to avoid all dependent loops. One other thing to remember is if you're transporting a patient, you have to disconnect them from suction. Do not clamp patient tubing during transport. The patient has the protection of the water seal anyway, so you're okay. Don't clamp it. Now, if you take a look at the picture over here on the left, you'll see that the collection chamber itself is going to hold 2,500 cc's before it needs to be changed. Then yes, it has to be changed, and we can do it the same way we did it in the previous video and the slides that I showed you, where you prepare the next one, clamp it off, and swap them out quickly. Okay, we can take a look at both pictures here. The one on the right has the blood recovery system. We'll talk about that later. and you can use it also without, but you have areas marked in red and areas marked in blue. The areas marked in blue are the suction control chamber, and the ones in red, those are the water seal chambers. So let's talk about the water seal chamber for a second. That's the one where you're going to add it up to the 2 centimeter mark. Now you want to keep an eye on that, because if they're on it for any length of time, you might notice some evaporation and you might have to add a little bit more. If you overfill the water seal chamber, to withdraw water, you're going to need a syringe with a 1.5 inch 18 gauge or higher needle on it. And then you stick it downward through the self-sealing diaphragm on the front of the chamber. That's where that dot is, right in there where you've got the scale that goes from 0 down to 5. Okay, now moving on, let's talk about the suction control chamber. Okay, so you have the water seal chamber and you have the suction control chamber. The suction control chamber is the one that's in blue. So when you turn the suction on, you don't want it so aggressive that it's bubbling out all over and it's getting into the suction control chamber. So what you want is you want gentle and controlled bubbling in the suction control chamber. So you can check the unit periodically to ensure that there's adequate suction is being applied to the unit and that gentle bubbling is present in that suction control chamber. Now there's a note here from the manufacturer, and it says, in the presence of a large patient air leak, airflow through the Pleurovac unit may be increased by increasing the source suction. This will not increase suction imposed on the patient. If the doctor has ordered gravity drainage, the suction tube should remain uncapped and free from any obstructions to allow air to exit and minimize the possibility of a tension pneumothorax. So don't clamp it, don't turn any valves off, just leave it open to atmospheric air. Okay, let's discuss a little bit of troubleshooting with this unit. So let's say you have some bubbling in that water seal chamber that we talked about previously. Okay, so what are we going to do? Well, let's start with one. You're going to check and tighten the connections and see if the bubbling still continues. Then you're going to test the tubing for leaks. If a leak exists, it may be at the insertion site. We don't know. So you're going to go through the clamping and testing just like we did in the very first part of the video. And if you find that the leak is up near the patient's chest, you're going to have to remove the dressing and assess the site to see if there's anything that you can do about it. And there's kind of a note here that just says, if you cannot see or hear any obvious leaks at that site, the leak is probably from the lung. So replace the dressing and see if the leak persists. Okay, a little bit of a side note. If you see that the bubbling is occurring with respiration, in other words, it's occurring on exhalation when the patient is breathing spontaneously, the most likely cause of the source is the lung. So you're okay, there's nothing to worry about. In a patient with a mediastinal tube, there should be no bubbling or movement in the water seal or the leak, any kind of a leak at all. So lack of bubbling is normal in that case. Of course, always notify the doctor if there's any increase in your leaks or any unexpected air leaks that are not corrected by the simple actions that we discussed. Now what you want to notice in the photo above, and we'll get into the blood recovery system at another time, these are two different models from the same manufacturer, Teleflex. So I'm showing you both for completion's sake on the video. The one on the left is the one that we do the in-services and the teaching about. The one on the right, it's another model, and this one's capable of blood recovery. So like I said, we'll discuss that in another video. This has been long enough, but remember, your troubleshooting is the same as we did in the very beginning of this video. It's no different with this one when it comes to the troubleshooting, trying to figure out a leak and so forth. Okay, so before we conclude the presentation on these chest tube drainage systems, something interesting that I ran into and I didn't think about it. I was talking with a friend of mine when I was working, and they said, hey, look, that's really great. I mean, we learned how to fill the chambers, we learned how to hook it up, and we know how to do all these things, but I never really understood how the chest tube drainage system really worked itself. Is there any way that you could explain it? And so I did a little bit of web searching and I came across this picture here. So let's take a look and let's see, that you have fluid or blood coming from the patient and it comes down into those collection chambers and it's showing it to you here in the red. But what happens with the air movement? Well, the air coming out of the patient, you just follow those yellow arrows. You'll see where it goes down through the water seal chamber. It comes up, and then it's evacuated out due to the wall suction. And you'll see in this the water seal chamber showing you, that's where we do the 2 centimeters of water pressure. And the other one to the left of that is a suction control chamber, and that's where you do the negative 20 centimeters of water pressure. And it gives you an explanation up here. I will leave this up for a few more seconds longer. That way everybody has a chance to look at it, kind of see and think about it and understand how these systems work. Okay, I'm going to go ahead and conclude the discussion on these chest tubes drainage systems and the Teleflex. I hope everybody got something out of this, or you got a better understanding now on how these chest tube drainage systems work. A little bit of troubleshooting, and I hope you enjoyed it. I hope you folks have a good day.